hormones. Then we looked at the nutrition care pathway. We looked at the nutrition interventions, things to do with the enteral feeding, things to do with the parenteral feeding, peripheral and the total parenteral nutrition. Yesterday we looked at nutrition assessment. We looked at the forms of assessment. We looked at the anthropometric assessment. We looked at biochemical assessment. We looked at dietary assessment, where we're taking the dietary history. We're looking at the 24-hour recalls, food frequency questionnaires, food consumption scores, and etc. Doing the household dietary diversity scores. We looked at also forms to do with the clinical assessment, where we are looking at the signs and symptoms. However, this was not captured, but we will capture it later on, as we'll be seeing in our further engagements. We had looked at further and did some calculations on that. But today we are going to interest ourselves and delve deeper into understanding of malnutrition, because at the end of the day, we expect you, when you tell us that you are a nutritionist, one of the things you're going to be able to combat is malnutrition. Okay. We could argue that most of the things that right now we have been covering are not new to most of us. Okay, yeah, however much a few things have been coming in handy, but I believe these things are all not brand new to us. Okay, so today we are going to interest ourselves with a deep understanding of malnutrition, and we are saying malnutrition refers to a condition resulting from improper or insufficient diet. We will understand why we say improper or insufficient. Okay, yeah, a long time ago, whenever people would hear about malnutrition, their minds would always go to the undernutrition. Okay, that is where people usually would go to, but we are saying this is a condition in most cases where the individual's diet lacks the necessary nutrients for proper development and health, and it can manifest in both undernutrition and also overnutrition. Okay, so for undernutrition, we are looking at the insufficient intake of the calories, the proteins, and the other essential nutrients. As for the overnutrition, we are looking at the excessive intake of calories, and that would lead to obesity, like we had calculated using the body mass index earlier on. So when someone comes and tells you you're malnourished, you need to ask which form of malnutrition. Okay, yeah. Though some people, like I told you, I had told us earlier, another form would be the micronutrient deficiencies that are always very silent, that people don't usually talk about, but they also exist. So it would be proper for you to tell someone that you're malnourished but you're overweight. Okay, yeah. The word mal alone, mal, means bad or poor or something that is disliked. Okay, so that bad nutrition, let's say in a layman language, is what we are trying to say, and we are saying that malnutrition on both ends, whether it is the undernutrition, whether it is the overnutrition, whether it is the micronutrient deficiencies, we are saying these have serious consequences on physical and mental health and well-being of particular people, and also the different categories of people that are vulnerable. Let's say, for example, the pregnant, other children, and other people alike. For the WHO World Health Organization definition, we are looking at the cellular imbalance between the supply of nutrients and energy and the body's demand for them to ensure growth, maintenance, and specific functions of the body. We realize that different nutrients play key roles in the functionality of the body and also the systems that depend on them. The impact, we are looking at the greatest risk factor for illness and death globally. If you look at statistics are showing that a lot of people in the world are hungry, and this is resulting from poor policies. But you could also talk about the poverty that comes in, the conflicts coming in, the unemployment, and also you could be looking at crop failures and also those inadequate social safety nets where we are looking at the absence or inadequacy of government assistance programs such as the food aid and all those things. But really, uh, uh, a lot can be said about that, but if nothing is put into practice, then we will realize that people, and also FAO is saying that a lot of numbers are still going up in issues to do with hunger. That is why, if you're looking at the projects that are being written right now, people are looking at ways of preserving the climate because I think global warming is coming up. Beg to be corrected, but more than 700 million people worldwide. I think it is around 700 million or something like that. Do not have enough food. That means these are undernourished. When we talk of people not having enough food, we are looking at undernourished. When we are saying people have a lot of food that they are overeating, then those ones are overnourished, which is also a form of malnutrition, I should say. Overnutrition and undernutrition, I think we have exhausted a lot to do with this, and we are saying undernutrition mainly results from inadequate consumption and poor absorption. Okay, you could be eating, but then whatever you're eating is not being absorbed well. Then we go to our next stage, or excessive nutrient loss. You could be eating and it is being absorbed, but you're doing strenuous activities whereby you're losing these nutrients in and out. You're overusing the body nutrients, or you incapacitated by a particular illness or a particular sickness, and this will lead to excessive loss of nutrients. And what happens is it's not that it's the food that is lacking, but then the consumption is there, the absorption is there, but then the nutrient processes are too much and you're not meeting them. That means you're going below your recommended dietary allowances on those particular nutrients. And as for overnutrition, we are saying this refers to a condition where someone consumes more nutrients than their body needs and uses, and this can include excess protein, carbohydrates, fats, vitamins, and minerals. However, people always look at proteins in most of those diets. We will, I think, look at that for particular conditions, and you will see that people prefer going for more proteins and more carbohydrates because at the end of the day, people know that proteins cannot be stored in the body. I hope we all know that. Okay, the body will use the proteins that it needs to use for those particular functions, then the rest will be excreted. Okay, form of urea and other byproducts. However, for carbohydrates, these ones are stored. The glucose is turned into glycogen, then other processes till the adipose formation, adipose tissue, and all that. So then the fat starts accumulating. For the fats and vitamins are not stored. Same like the minerals, those are not stored. What is required is used, then the rest could lead to toxicity of the body if at all they are in extreme amounts, leading to other challenges. For example, excess of iodine will cause goiter. However, also inadequacy of iodine will still cause goiter and hyperthyroidism and hypothyroidism relatively. So a classification of malnutrition, you realize that different people have come up to classify the malnutrition, and we are saying we have these percentages based on weight loss. Okay, yeah. So for classification based on loss of body weight, we are looking at the mild, moderate, and severe malnutrition categorized by percentage weight loss, with a percentage weight loss of 85 less than 85 to 90, then we could say that is mild. With a percentage loss of less than 75 to 84, we would say that is moderate. Then for a percentage loss that is leaving us at only 74%, would say that is very severe if we are left with only that percentage out of the 100%. All right. Classification of malnutrition, we still have this welcome classification, which is a little, I wouldn't want to use the term a little bit out of the books right now. People are more into using these terms of protein, energy, malnutrition instead of this. But then let's interest ourselves. We're not going to be working alone in those settings. So the most of the people you'll be interacting with will be telling you about these. They will be talking about the kwashiorkor, they will be talking about the marasmus, they will be talking about the marasmic kwashiorkor. Okay. Well, for the protein energy malnutrition, we are saying that this is characterized by inadequate intake of proteins or energy or calories. And it encompasses a range of all these things where people are going to be talking of the kwashiorkor and they will be talking of the marasmus. Earlier on, we would talk of kwashiorkor where we are looking at only proteins. Okay, inadequate intake of proteins or utilization, as we had talked of. You could be taking in the proteins, but then they are not being ably absorbed, or they could be absorbed, but then you're having a lot of losses. So that's where we are looking at the kwashiorkor. Then for the marasmus and the marasmic kwashiorkor, here really we talk about all the macronutrients. Okay, we know the major three macronutrients: the carbohydrates, the proteins, the fats. People have valued vitamins and minerals are always bound to be put together. Yes. What are the common causes of malnutrition? We have anorexia, like I told you. This is loss of appetite due to various factors. The factors would include sickness. Factors would include these social factors, the lifestyles. People really don't want to eat because they fear they will look ugly. Maybe people want to maintain a particular weight, and this happens mostly to the females. But of late, the generations are changing. The females are always taking lead. They are trying to be out there and outcompete men. So it is very rare. Back then, it was the men. The men would wake up and know that the only way they can get a beautiful woman is by them trying as much as possible to make all the money that is out there. But nowadays, the women have also gone to school. They have the money. So these days, you're going to see a generation of men also trying to look nice, go to the gym, and all those things. So body image matters so much in this day and era. Disease related, we are looking at chronic and inflammatory diseases. These could also cause malnutrition. For example, it is very rare if you're having a cancer patient and this person is in stage 2 or stage 3 and they're not malnourished. Most of these diseases will lead to this. And also, like we had told you, for those bowel inflammations, we are going to have to think that this person will have inadequate intake for the next 5 days. Then we'll prescribe the enteral feeding, or if more, it will be the parenteral. And we know in that particular period, we won't be meeting the recommended dietary allowances of those nutrients. So what happens at the end of the day, this person will be malnourished. For the physiological factors, anxiety, depression, and dementia, it is only in Africa that we don't believe that people can be depressed, but out there, people are depressed. Okay, people have challenges. That's why whenever you walk into your place of work, or even if you're just going home, try to understand how people are doing. Okay, this is not only a life skill, but it will also help you do your work better, and also it will help someone else avoid malnutrition. Okay, yeah. In these psychological factors is where we also put the stress levels. People are really stressed. Remember, the world is running very fast. Okay, people are stressed about a lot of things. And nowadays, back then, our parents and our guardians never used to have a lot of stresses because they would only care about what is taking place around them. in their community. But right now, I need to know what is happening with Israel and Gaza war. I need to know what is happening in Russia and Ukraine. Following African Cup of Nations. I'm still the same person supporting Real Madrid. I'm still the same person looking at Arsenal. I'm looking at models, which artists release their songs. So those are the things come in handy. So it's good to find some time for yourself and live on your own. Social factors that we cannot undermine, we can look at poverty and famine really, and also institutionalization. Institutionalization, we are looking at hospitals, we are looking at schools, we are looking at prisons, and also we could talk of government policies. I hope we know that. Am I forgetting? Is it called the framework? The framework of malnutrition, something like that. I'm forgetting, but where we have the basic causes, the immediate and the underlying. But however, it's changed of late. I will be discussing it later on in our engagements. So, factors contributing to reduce food intake, we have anorexia, like I've told you, this is a pathophysiological or psychological. And social problems leading to loss of appetite, where we have the anorexia nervosa and the anorexia bulimia. These are really big cases, and people have written uh, papers about them uh, in those countries where it always happens. And also, we would like to know that these are both serious eating disorders, okay, and they can have a lot of consequences. For anorexia nervosa, we are looking at people fearing that intense weight gain, so leading to these people restricting their food intake severely. As well, for the bulimia nervosa, people will consume large amounts in a short period of time, and then or sometimes try to do what is it called? People usually will call it regurgitating. They try to vomit back everything they've eaten. Yeah, so anorexia is something really that challenges human beings out there. And for the disease related, we have looked at those, and also childhood malignancies affecting eating abilities, and also food taboos. In Uganda, we had actually, from the tribe that I come from, Amamuganda, we women back in the day never used to eat meat and eggs. I think this was a trick by the men to enjoy those delicacies alone. But then, for example, if it's now the young girls whose bodies are growing, or if it's a pregnant woman who we actually encourage to eat fish, to eat meat, to eat eggs, but then you're giving all those delicacies and the foods that are rich in nutrients to men because of the food taboo. So we could talk of those here. Treatment side effects such as the nausea and the chemotherapy and the radiotherapy. When you look at the people who are being exposed to chemotherapy or being treated in this form of way, these people usually report to have a metallic taste. I don't know how I can explain a metallic taste, but yeah, they report to have numbness of the tongue. So they really can't eat. This eating is also a sensation. That is why sometimes people eat and eat. Someone will only eat until they cannot eat anymore. That is when they will stop. But yeah, surely that is what I would like to say about that chemotherapy. That in chemotherapy, some people really can't eat a lot. Okay. Also, with the psychological factors, we've looked at those. We've looked at the anxiety. We've looked at the depression. However, we could also go a little back at chemotherapy, and we say sometimes there is nausea. Nausea is that feeling of wanting to vomit, and also we could talk of the fatigue, and also vomiting itself happens. And sometimes people feel bad about themselves because now they have started losing the hair, their bones are paining because chemotherapy is a little painful. Okay. Yeah. So people really won't want to eat when they're undergoing that. Risk factors for malnutrition, infants and adolescents. We are looking at vulnerable due to growth and development needs. I hope we all know the rule about the first 1,000 days, the window of opportunity from conceiving to the first to the child to the first 4 years. Okay, the window of opportunity is really big. That in that period, for whatever happens to a child may not be reversible. That is a period where people get stunted, the children get stunted, and you can no longer correct that stunting of what people call cretinism with the lack of iodine. If iodine is not given in its adequate amounts, we will look at cretinism, and also when the pregnant women are not given folic acid, we look at the neurotube defects that could develop, and also other conditions that could come in. And also, when we talk of the infants, really, we are looking at this as a period for growth. Okay, now the child is no longer feeding from the mother. For example, they are no longer feeding from the umbilical cord. Really, all the nutrients the child came in with are no longer sufficient, and also the nutrients in the milk are now no longer sufficient. That's why we want you to be ambassadors out there and teach people about complementary feeding. That at 6 months of age, a mother is no longer giving the child the adequate nutrients the child requires for them to prosper and grow and develop well. So what happens is the mother needs to step up a bit and give the child those foods that are rich in those other nutrients that are not adequate in the breast milk. For the adolescents, remember the adolescents are now experiencing puberty. For not puberty, sorry, puberty and adolescence are quite different. But adolescence is the first step to puberty, and with adolescent, most adolescent girls are now able to get pregnant, and also their menstruation has started. And what is the menstruation? We understand that there are losses in particular nutrients, and these need to be replenished concurrently. So that is a risk factor with older people, especially those with chronic illnesses residing in these nursing homes. We realize that by the time we get old, most of us have issues with our gums, and the teeth are no longer there. I think they call it denti something about losing the teeth and problems with chewing. The jaws are weak, and we will also look at wearing off of most of the inner linings that are required to absorb the particular nutrients. So we need to take a little more caution. That is why we always try as much as possible to feed these elderly on porridges, purees, and those foods that are easy to absorb. Really, sometimes people say the older you get, you start going back to your first stages of being a toddler. That is why in most of our traditional settings, the older woman, you give them the child so that they nurse the child, because people tend to say that these people are almost now, since the other one is almost at the end of life, she's coming back, this one is just starting life. So they match a little bit. Poor individuals, here we are looking at lack of adequate supply. Really, back in the day, people who are poor used to have food. But right now, people who are poor don't have anything completely because they've been displaced. And being poor doesn't mean you're not enjoying life. People can enjoy life, but they're still poor. They don't have money to adequately meet the food supply, because really, when we talk of nutrients, we have a particular snack here. It's called Rolex, but then people have found ways to modify it. It is either chapati and beans or chapati with the egg. That is what the youth all over Kampala are going for. Residents of developing countries have limited access to nutrition resources. Really, okay. Well, we are not very blessed with the types of leaders we have to help us go a little bit and understand most of these things and benefit from them. Yet we pay the biggest taxes, and we have the biggest resources that the world has to offer. The pregnant women, I think I explained this, increased nutrition requirements during pregnancy. The servings also increase, and I think we'll also be talking about that when we are looking at feeding of the various conditions, and also various persons, individuals of in socioeconomic hardship, lack of sanitation, education, or food preparation means you can have the food, but then you don't have the means to prepare the food. The education, you're not in the know of how to eat. This information, you see, for you, whenever we tell you to eat a balanced diet or to improve on your dietary diversity, at least you have something that comes to your brain. But people out there eating a carbohydrate and a carbohydrate. Okay, he's eating cassava, but then what would be the source? The person is taking porridge. Okay, yeah. Lack of sanitation, actually, when, for example, we are looking at new arrivals entering into refugee settings, there are some projects that are already targeting this sanitation. That however much World Food Program or UNHCR is trying as much as possible to give them food and give them all these necessities or edibles, cooking oils, and all those other dry rations. These people still, after eating, they are going to do open defecation. And once they do open defecation, the cycle will come back with the immediate causes of malnutrition, or the immediate cause of malnutrition or undernutrition will be disease. Cachexia, when we talk of cachexia, this is a term that as wasting syndrome that is associated with chronic and end-stage diseases. Symptoms include undesired weight loss, physical weakness, changes in metabolism, increased lipolysis. Okay, and we are also looking at the protein turnover, and also we are looking at glucose intolerance. So sorry, when we talk of lipolysis, we are looking at this in most cases is the process by which most lipids are broken, that are broken down into fatty acids and glycerol, and this occurs in those fat cells of the adipose tissue, but it can also take place in other tissues. And this is majorly regulated by those hormones. If some people did some, is it biochemistry, things to do with the glucagon, the cortisol, and etc. Maybe we'll look at those. So this lipolysis is key in metabolism because it maintains the energy balance of the body, and if this occurs, the dysregulation of lipolysis occurs in situations such as obesity and insulin resistance, it could lead to health problems. But here we are looking at this being the lipolysis being increased, still it would lead to the metabolic syndrome. Like I had said, then for cancer, cachexia, we're looking at progressive weight loss, anorexia, muscle atrophy due to the malignant growth. Yes, this is what we were talking about of the protein energy malnutrition, and we are saying it could also be known as protein energy undernutrition. We're referring to a spectrum of conditions caused by lack of dietary protein and calories in the various proportions. So physical signs of PEM, we have the weight loss and cachexia reduction in muscle and body tissue mass observed in the legs, arms, buttocks, and the face. I remember we had those things when people were talking about them, baggy pants, the moon face, etc. So for the protein energy malnutrition, we have edema. Edema has come due to fluid retention. If people remember the cerebral doctor, and also we had talked about fluid retention earlier on when we were talking about malnutrition in our earlier class. With edema, I think we know that for malnutrition, it should be bilateral pitting edema. Okay, we are not only talking about the edema that comes, because there are other forms of edema that will come. For example, people who get malaria get edema. People who have issues with their lymph nodes still get edema. Okay, so for malnutrition, you're looking at bilateral pitting edema, and I think in most cases people talk of pressing when they are assessing them. I think we'll see that later on in a class, but we really know that when these people come and they are odematous, we treat in ITC. Okay, yeah, but then they don't only come with odema, they come with also these other challenges, coming with the thin hair, the skin lesions, the fatigue, and also the muscle wasting. And this is very common in our developing countries compared to the high income countries. Whereas with low and mid income countries, we have some of these challenges in our LMICs. So oral changes, we are having the red swollen lips and gums, the muscle cramps and pain. You will see when these children come to your clinics or when they come to your places of work that they are very irritable because of what they are going through. That is why uh, in most cases people mistake this with a child is poor attitude, but they are not really doing well with the muscle cramps and pain. Then also the lethargic actions of the child. We've talked of the skin and hair changes, the dry and peeling skin, and also here is where we'll talk of the skin lesions still. For symptoms and causes of both of these PEM, really we don't expect you to be using kwashiorkor and marasmus, but you will be using PEM, the protein energy malnutrition. Your nutritionist friends will be able to understand what you're talking about. For kwashiorkor and marasmus, there are two forms of the protein and energy malnutrition, where we looked at kwashiorkor being inadequate protein intake and low essential amino acid concentration, and for the marasmus, we are looking at inadequate intake of both protein and energy. And energy is from the fats and the carbohydrates. So all the macronutrients in marasmus are inadequate. But for kwashiorkor, basically they are talking of only the proteins. So for the proteins, that's why we have the edema, the bilateral pitting edema, the wasting, the liver enlargement, the hypoalbuminemia, then the steatosis, and also the pigmentation of the skin. Excuse me. Okay, I was saying with the kwashiorkor, this is where we are having the edema, the wasting, the liver enlargement, the hypoalbuminemia. When we see hypo, we know that that is low. Then hyper is high. So albuminemia, that is the albumin in blood. So the albumin in blood is reduced. Steatosis, we are looking at this is sometimes associated with a fatty liver. It's a condition where we are looking at accumulation of fat in the liver. People have argued that maybe this is more to do with people who are alcohol abusers, okay, but it also happens to other people, and it's also key. It could happen when we are looking at insulin resistance in diabetic clients. For marasmus, we're looking at severe wasting, minimal subcutaneous fat, muscle wasting, and non-normal serum albumin levels. For nutrition management of kwashiorkor and marasmus PEM, we're looking at nutrition rehabilitation for these conditions. Should be gradual and carefully monitored to avoid complications like thyroid feeding syndrome. Yeah, okay. I hope you all remember what feeding syndrome was from our yesterday's lecture. And we are saying start with small and frequent feedings that are easily digestible and nutrient-rich foods, so that we do not overload and shock the system, and gradually increase the calorie and the protein intake as tolerated. For any intolerance, please try as much as possible to withdraw. Like I told you earlier on, that it is okay to underdose than to overdose when it comes to nutrition. Okay, yeah. So addressing underlying infections and other medical when it comes to undernutrition, especially for a child that you're treating in ITC. So addressing underlying infections and other medical conditions that come in handy, because you may be only concentrating on malnutrition, but then for their challenges for people who have TB, TB tends to show uh, I'm forgetting TB for patients that have TB. These people become undernourished. Okay, and also for people who have malnutrition, these people are more susceptible to TB. However, there is an issue whereby a child will show you that they are gaining. Okay, I'll come and give a proper explanation next time. But when you're treating a child with TB on a nutrition ward, this child will get well. Okay, the child will show that they're improving, but then they will default because they have TB on them. The reason is because there is that immunosuppression that the TB does, however much you're trying as much as possible. I'll give a better explanation on the scenario uh, later on. For the Kwashiorkor, we're looking at focus on providing high quality proteins and those sources we know the milk, eggs, meat, the beans, the soya, the cowpeas, etc. And also we are looking at limiting fat initially due to the potential liver dysfunction. And remember, the proteins are broken down by the liver into those essential amino acids, etc. And also provide essential vitamins and minerals, sorry, particularly the B vitamins and also the potassium and magnesium. So, with both of them happening at once, you're looking at gradual increase in both calories and proteins to address deficiencies. Prioritize easily digestible carbohydrates such as rice, bananas, bread, etc. The porridges really should be given every time a person shows that there is appetite. Okay. Yeah, and also provide these essential vitamins and minerals. It is rare that people want to, whenever we talk of sickness, people really want, really forget about the importance of the vitamins and minerals. That orange is of the same importance like the chicken you're buying for that sick person. So please, whenever you go to see your people who are sick, carry that bucket of fruits or that basket of fruits because trust me, people are going to be buying this person Minute Maid, they're going to be buying for them Honor, or they're going to be buying for them Red Bull. Is it Red Bull, that energy drink? Lucozade and all those things. But at least you as a nutritionist, please move with these fruits to those individuals and don't buy these GMOs because the GMOs always look good on top. If it is a mango, it is seedless, but it looks very good on top. So please avoid those GMOs. I don't want to be crucified when I talk of GMOs. So let's proceed. And for the marathons, please focus on increasing calorie intake fast. Like I told us, then using easily digestible carbohydrates and fats, then gradually introduce the protein. Why we are putting in the calories first is because you remember these calories will help us do the sparing effect of the proteins that are now being depleted to form energy. Then if we give the proteins as tolerated, then we'll come and provide the essential vitamins. etc. So important considerations we're looking at electrolyte imbalances, the sodium potassium pump, don't forget that, and also people have budget the serum albumin is something to be watching out for, and this would also be occurring during the feeding syndrome like we had talked about earlier. Special feeding methods like the nasogastric tubes may be necessary in severe cases, and also breastfeeding should be continued and reintroduced whenever possible, especially in infants. That is what we were saying that, for example, if a child is sick, even if a child is on medicine, try as much as possible to breastfeed this child because we don't want the child to miss out on the nutrients that are coming from the breast milk. And also nutritional counseling and support are crucial for the long-term management and prevention of relapse. We don't want these people going back to the exact situation that we tried to rescue them from. Clinical symptoms of vitamin and mineral deficiencies, these are many. These are many, but really most of them cross-link. That is why it is key when before we talk of nutrition, before we talk of micronutrient deficiency, it is always nice for us to probe further and understand and use different methods of nutrition assessment, like we had seen. Either taking the dietary assessment, where we are looking at the dietary history and also looking at the biochemical assessment, really to understand and to know which particular nutrient that is being inadequately taken into the body. But we'll look at some of the few, looking at numbness, muscle aches, irregular heart rhythms, seizures for the magnesium deficiencies, eye damage, the dry skin. Here we'll see a lot of these really because most of them, actually, there are very many. Okay, even if you wake up one morning, you will see yourself speaking a lot about the corneal ulcerations, about the angular stomatitis, about the hair losses, about the what is that thing you call it, pin and needles and pins, etc. There are a lot of symptoms and signs. There are weak bones with the calcium deficiencies. We have a lot really for you to pick from when it comes to that. So, screening tools for malnutrition detection. When we talk of screening tools, really here we are not talking about the weighing scales and the height boards, etc., but we are looking at those tools that people really use out there, because it's a combination of those individual small assessments that we do. And in this, really, we have a number of tools. We are seeing the prevalence here. The disease-related malnutrition affects significant percentage of inpatients, home care units, and in the nursing homes. The nursing homes are those homes for the elderly people. We have the MUST, we have that the mini nutrition assessment tool. We have a number of them. Uh, Sorry about that. Uh, okay, and these you will be seeing, but maybe for the one I'm well versed with is the mini nutrition assessment tool. Really, this one I used for my undergraduate, and it has things to do with the dietary history. It has things to do with the economic activity the individual is engaged in. It has a part for the BMI. It has a part for the dietary diversity score. So you see, this tool is also scored depending. I think was it 20, if I'm not mistaken, the total. So the far you're coming from the 20 is the more malnourished you will be. Yeah, but interesting tool that we really need to look at as people who are going to be practicing nutrition. But actually, for the mini nutrition assessment tool, it was a tool developed by NESO. I hope we know that NESO that is in charge of making that infant formula, that company that really produces infant formula. Yeah, that they developed that tool. I remember capturing information using it. Causes of hospital malnutrition, lack of global interest in nutrition. People really don't look at nutrition being of concern, but really now we are seeing that the world is taking a slight change, and people are starting to give nutrition importance. Nutritionists are being paid heavily. Actually, now the athletes are the ones putting the nutritionists on map. For example, most of those influential athletes have personal sports nutritionists, because they know the role the nutrition plays in those avenues. And you know that with these people that have a lot of following, we will at the end of the day be appreciated. But when we come back to the hospitals, you will find that a hospital will have a nurse, a hospital will have a cleaner, a hospital will have a doctor, but then when it comes to the nutrition, they feel they don't need a nutritionist. At the end of the day, since a child has come and the doctor thinks now they want to rejuvenate the child very fast, they will start loading the child with all the types of fluids that they have at their disposal. And at the end of the day, they will lose the child, but then because the nutritionist was not around. And also, this is a cry out to everyone who will be practicing out there. Please try to raise the flag of nutrition high. For things you don't know consult, for things you can't do, please go and talk to a friend. Or come to Google and consult, open Google Scholar. These days we have these language bots such as GPTs and all those things. However, those ones are still under a lot of scrutiny. But if God helps us and most of these artificial intelligence languages are good, then we will be good to go. It's not that I am decampaigning against human involvement in most of these things, but now that is the era. Okay, we can't do without artificial intelligence, whether we like it or not. That is why if I give an assessment and someone uses artificial intelligence, I'm not going to be biased. The problem is going to come that you only relied on artificial intelligence without the use of your head, of which that one can easily be known. But using artificial intelligence coupled with your brains, it will give us really good work and we won't have errors, spelling errors, typing errors, things losing meaning, etc. Also, we are looking at the importance. Highlight the need for improved nutrition practices and standards in healthcare settings. Let's advocate for us to have nutritionists starting with the health center tool at least, okay? Because now those ones are covering bigger areas. But it also depends if the health center one is covering or is having a lot of people that it is serving, then at least let's say for every for every health center that serves around 1,000 or 2,000 patients per week, let's put a nutritionist on that health center. Okay, also let's proceed with the treating of the malnourished patients. Approaches to treating these patients are based on individuals' health status and nutrition needs. Like I told you yesterday, not a one size fits all. Different people will come presenting with different needs. Feeding syndrome, we cannot express this, we cannot emphasize this more. The treatment options, the enteral and parenteral nutrition when normal oral food intake is insufficient. And also fortification of foods. Really, when I was, I think, teaching this same class on food product development, we talked about the fortification of foods and also really we can now ably talk of the oral supplements which we do not always prescribe, but then that is what we have in case things have gone wrong. I wanted to put this in somewhere into the slides, but I failed. So I was like, okay, let me put it at the very end of the slides because I was trying as much as possible to find where to put it. In our malnutrition, there are these terms that you always come across: the underweight, the stunting, the wasting. Underweight, these are terms. Underweight, stunting, and wasting are terms that are commonly used by WHO and UNICEF to classify malnutrition in children aged 5 for age. A child is supposed to be of a particular height at that particular age, but then the child has a low height for age, and this is indicating also chronic malnutrition and impaired growth. And this is where we were talking about the window of opportunity that once someone is stunted, they are stunted. These are the same people you send to the parliament to start debating you further because they cannot look further at the developing of the country. All they can see is becoming rich. And for the Sudanese, I'm really, this is where things become very challenging. And when you look at the charts that we have, the WHO charts that we have, these charts are used, they didn't use the ideal, what should I say, the ideal cases when they were making these cutoffs. Okay, so if I'm measuring a Sudanese child, South Sudanese, I hope I'm okay to use this example. The child will show that this child is of normal height. Okay, but when it comes to what the normal height is in South Sudan, really you people are very tall compared to some of us. Some of us, our heights, God did what He could. He gave us something. But for you people are extremely tall, And when we use these measurements, the WHO cards, we'll see that so most of the South Sudanese children will pass for this stunting. Okay, they will show that they are not stunted. But if we measure them with the ideal child, the ideal height of the child who is in South Sudan, then that child will be stunted. So that's where these things are always challenging. And I think that is a disadvantage we give when you're testing for stunting somewhere. Wasting, we're looking at low weight for height, indicating acute malnutrition and recent weight losses. So, friends, this is what I had for us today. But really, it would be good if we can talk about malnutrition, talk about the forms of malnutrition, the under, the over, the micronutrient deficiencies, be able to talk about the common causes, feeding syndrome, find something to talk about the protein energy malnutrition, really interlinking the kwashiorkor and marasmus, the marasmic kwashiorkor, the importances of important considerations, etc., and also the screening tools, and also these underweights, stunting and wasting classifications of malnutrition and underweight. So, friends, this brings us to the end of today's engagement, unless we have something to ask. Yes, is there anything?
Thank you so much.
You're welcome, Tito.
On my side, there's nothing to be said.
There is